Welcome to this session on value-based healthcare and climate change. Can value-based healthcare support environmental stewardship? I'm Kylie Woolfolk and I bring this session to you on behalf of the Australian Healthcare and Hospitals Association. Today we'll be exploring the alignment of two concepts in practice, value-based healthcare and environmental sustainability. But first up, some housekeeping. For those joining us virtually, you can send your questions by clicking the Q&A tab on the right side of the screen. For those who are in Barcelona, you can send your questions by first downloading the Congress app. Once logged in, click Q&A from the home screen and select this session. To get to know us more, you can view our profiles in the Congress app. So first up, we have Dr. Anna-Greta Hunter, who'll be focusing in particular on avoiding low-value healthcare in reducing the carbon footprint of our health system. A physician and cardiologist with a focus on preventative care, she's a senior lecturer at ANU Medical School and the Human Future Fellows for the Australian National University College of Health and Medicine. She is the chair of the Commission for the Human Future and a member of the ANU Institute for Climate, Disaster Science and Energy Change. Thanks.
My name's Anna-Greta Hunter. I'm a cardiologist and the Human Futures Fellow at the College of Health and Medicine at the Australian National University in Canberra. And I'm coming to you virtually from Canberra at the end of one of our lockdown periods. It's a wonderful time for us to rejoin the global community again at what is quite a remarkable time in our global history. Firstly, I'd like to acknowledge the Ngunnawal and Ngambri people, the Indigenous Australian peoples on whose land I'm currently sitting. It's important to acknowledge the significance of our Australian Indigenous heritage, that our Indigenous peoples never ceded their lands or their culture, and to reflect on the remarkable understanding that is generously shared by Indigenous peoples, particularly reframing health and wellbeing in a deeply holistic way that encompasses both people and place. I'm going to speak today about climate change in the health system. I'm particularly interested in value-based healthcare and low-value healthcare, and whether putting those two things together might help us to reduce the carbon footprint of our health system. Climate change and health are deeply connected. We have had a tendency in our health system to consider human health through the biology of disease. This pathological and biological focus has seen us focused on drugs, procedures and interventions in a quest to improve human health and wellbeing. Increasingly, we are aware that human health and wellbeing is beyond biology, that the social determinants of health and wellbeing play a dominant role in our health. The final element of this framework is, of course, the environment. Temperature, air quality, food and water security and access, where and how we live. The environment is another framework for health and wellbeing. Anthropomorphic climate change sees rising global temperatures. This graph on this slide is from the 6th assessment report from the IPCC that was released earlier this year. The rises in global temperature will increase the weather extremes and particularly increase the likelihood of natural disasters. Speaking today with a global audience, I'm particularly aware that every single one of us will have had a natural disaster in recent periods that was made statistically more likely by global warming. In the Australian context, of course, we had a textbook case for climate change associated natural disasters with the black summer that it was experienced over 2019-2020. The devastating fires started here in Queensland and slowly extended south down the Great Dividing Range through New South Wales into Victoria and saw profound impacts on our natural environment. Impacts on a native wildlife, which was devastating, and human health impacts, which were seen across our healthcare system, affecting all of the different types of health outcomes, with almost half of our population exposed to hazardous levels of bushfire smoke through that devastating summer. Climate change and health are here and now. Direct and indirect health impacts come from climate change. We will see increasing mortality from heat and from temperature, from food and water security impacted by drought and other extreme weather, and altered morbidity and mortality from changed patterns of our infectious diseases. Of course, there are also indirect health impacts from population displacement or changes to impacts on essential supply chains, leading to insecurity of food, water, and other essential products. These are just some of the myriad of ways in which climate change will increasingly impact on human health and wellbeing. Climate change is the greatest challenge of the 21st century, threatening human health and development. The longer we delay action, the greater the risks to human health and lives. This is, of course, from the World Health Organization in 2018. The time to act on climate change was a decade or more ago. The next best option is, of course, to act now, to take all of the decisions that we make in our lives, and particularly within our work and activity in the healthcare sector, through the prism of climate change and the impact that it has on our health and well-being, both now and into the future. So let's start by thinking about greenhouse gas emissions and where they come from. Internationally, greenhouse gas emissions are divided into three different sources. Scope 1 emissions, which are the sort of emissions that come directly from business activity. If you're running a factory, then your Scope 1 emissions can be significant, particularly if you're running something like a coal-fired power station. In the healthcare sector, Scope 1 emissions come from transportation and other industrial processes that can be part of running a hospital. Obviously, many hospital and healthcare facilities have a carbon footprint that comes from the different machineries that can be used. The second issue is Scope 2. Scope 2 emissions are indirect, and they come largely from our sources of energy, things that might heat and cool the infrastructure that we exist in. If we're buying 100% renewable energy and that covers both energy, heating and cooling, then we can rapidly decrease our Scope 2 emissions, which is quite profound and has flow-on effects. Several jurisdictions around the world have achieved this in their healthcare sector and in their community, and that includes the Australian Capital Territory where I'm based. The last part of the equation is almost certainly the most complex, and that's the Scope 3 emissions. Scope 3 are the indirect emissions that come from the supply chain, the embedded carbon footprint that covers both the production of goods and their transportation. If you're using vegetables that you grow in your garden, the Scope 3 emissions might be from the seeds or the seedlings, but they're likely to be negligible. If you're buying an MRI machine manufactured in a number of factories in different locations, and you're buying it to bring it from overseas, or you're buying vascular stents or orthopedic prostheses, the Scope 3 emissions are a significant factor. Scope 3 includes all of the elements of that harvesting and manufacturing process, the transportation and the supply chain carbon emissions. For most of us individually, Scope 3 emissions are the major component of our carbon footprint. That's true in our lives domestically, as well as in our professional experience. The number varies, Scope 3 emissions are the major component of our carbon footprint. And this is the case in healthcare too. When considering this, it's useful to tie together consumption of stuff and the carbon emissions that are Scope 3. Around the world, there are different fractions that are attributed from healthcare to the nation's overall carbon footprint. The number varies from around about 5% to 10%. An assessment that's been done here in Australia by Malik et al. That was published in the Lancet Planetary Health in 2018 estimated very reasonably that 7% of the Australian national carbon footprints from the healthcare system. And so where do we get that from? Well, it's very reasonable to assume that 7% is a good number, at least partly because the healthcare sector employs at least 10% of the Australian population. When we extend it to our caring population, those who are working in nursing homes and other care facilities, that in fact employment in that healthcare sector more broadly is a large minority of the Australian working community. Economic activity and employment are often reflected in carbon footprints because of this relationship with Scope 3 emissions and consumption-based activity. So we estimate that about 7% of the Australian carbon footprint comes from healthcare, and that 60% of that carbon footprint is from consumables or from direct consumption of stuff. Other proportions that are clearly worth mentioning and worth focusing on include the utility, so the sources of our electricity and energy, the travel that we do as part of the work that we do, and the waste system. And these are all potential targets for improving the greenhouse gas emissions of the healthcare sector. So what can we do to address the environmental impact of healthcare? It's obviously important to look at renewable energy use, to reduce waste and to see what we can do about recycling. There is, however, another element of the equation. Can we change consumptions around healthcare? Would that adversely impact health outcomes? Or could it be that reducing health system consumption actually improves health and well-being? Value-based healthcare is a really interesting framework in this context. There's a growing movement around the world, and one we're very proud to be part of here in Canberra and in Australia more broadly, that's exploring a shift towards value-based healthcare. Value-based healthcare provides a patient-centred approach to the design and management of health systems The central elements to value-based healthcare include being patient-centric, being outcome-focused, and taking a whole-of-system approach. Value-based healthcare may see patients trying to choose to avoid surgery if possible. There's some great examples that are out there, including the treatment of advancing osteoarthritis of the knee. There are a number of trials in progress and previously published that give patients the option of treatment with physiotherapy and exercise to avoid surgery, and that patient-centred progress and outcomes in that context are often preferred in contrast to the surgery. If a patient chooses to enjoy regular exercise and physiotherapy, perhaps with a personal trainer or an exercise physiologist, we know that there will be a small carbon footprint associated with that activity. But I think it's easier to negate the carbon footprint there using active transportation or carbon neutral transportation and carbon neutral electricity systems compared to the carbon footprint of a joint replacement. And so it's quite interesting here to be guided by the patient choice and to be very much patient-centred, giving people practical suggestions and ideas, and particularly giving them choice in terms of the approach that they take to their problem, in this case, osteoarthritis of the knee. We can look at similar sorts of interventions in cardiology. I'm a general cardiologist in clinical practice. There's an increasing amount of evidence that would suggest medical management of stable coronary artery disease is preferable, or offering medical management is a perfectly reasonable starting point. Often it would include an structured exercise program, and we know that exercise programs and supported conversations can be, one, carbon neutral, and two, benefit patients in ways that extend well beyond the management of the plaque inside the coronary artery. It is, of course, tremendously important to note that knee replacement surgery can be revolutionary for patients. That coronary artery stenting and bypass surgery can significantly transform a patient's quality of life, and that treatment with drugs, procedures and surgery have a real role to play in our healthcare system, and they can positively impact on our both quality of life and on survival. These treatments have a clear role to play. However, we do know that there's a problem with low-value healthcare, and that we have good data to show that we overuse many of these sorts of routine interventions and even the more invasive sorts of medical treatments. And if our goal is outcome focused, if we want to be led by our patients and what they regard as important, quality of life, for example, we might find effective interventions that have a much lower carbon footprint associated with them. We need to talk about low value and no value healthcare. Low and no value healthcare offers little or no benefit and still risks that iatrogenic harm involved with hospitalisations and procedures. Research done here in Australia has shown that around 30% of the healthcare that is delivered is either of no value or little value or no benefit. Perhaps even more concerningly, that 10% of healthcare that's practiced is of no value. When we're talking about examples of low value healthcare, overdiagnosis is a key element. Screening for benign conditions, screening in a situation where we might find that the pros and cons of that screening process are significantly more complex, and that often lead to compounding, cascading sequence of tests and investigations that are not focused on improving a particular person's quality or quantity of life. The quality of the healthcare system, which is often very difficult to know, is a dominant feature in the delivery of or the avoidance of low-value healthcare. Early recognition and conversations with patients about pros and cons of screening tests and other procedures are a key part of the overall picture here. When I think of examples of low-value healthcare, I'm again back in my profession of cardiology, that some of the work that we do on coronary artery disease and in cardiac rhythm disturbances may not contribute in a meaningful way to the patient's quality or quantity of life. Medical management is an important mainstay of some of the things that we do, and yet in Australia, a blocked artery that's identified with testing is often or routinely treated with coronary intervention. This Orbiter trial offers quite a remarkable view of this when we're thinking about it more broadly. They performed a sham coronary stenting and inadvertently demonstrated that coronary stents carry a placebo effect and don't offer clear symptom relief for patients. The pros and cons of coronary intervention have been well explored in a multitude of randomised controlled trials that show there really isn't a significant influence between medical management, coronary intervention with either stenting or bypass surgery. We need to be able to talk about that in a detailed way with our patients. When we look at it through the environmental prism of the carbon footprint, it again adds weight to the tremendous importance in having these balanced conversations as to whether to proceed or not with invasive treatment. A similarly difficult conversation can be around issues like breast cancer and prostate cancer screening, the complex analyses that have been done internationally showing that some of these routine screening procedures are much more complex than they seem. These problems prompt and often need a nuanced and more complex, often emotive clinical discussion. And I find myself wondering how much the healthcare system might reward these conversations with our patients that are at the centre of the sort of decision-making around consumption, treatment and tests. In healthcare system financing, we're dominantly remunerated by clinical activity, particularly procedures and consumption. Much less well rewarded for a more nuanced, patient-centred conversation which is focused on that individual's well-being. The shift to patient-centred outcomes may be one of the key elements provided by a value-based healthcare approach in trying to remove the low-value healthcare or no-value healthcare from our system. First do no harm is an oft-used phrase, but in fact in this discussion of the health system's carbon footprint, it is deeply resonant. Harm neither person nor planet. Consider the patient at the centre of treatment decision and choose to care for the planetary impacts at the same time. Use health system resources wisely and when able in a low carbon way. Clinical discussions should centre on quality of life and life expectancy gains, sometimes which can be quite small. Not doing something can be a powerful intervention, and talking about it is key to good clinical practice. Conversations with patients are generally not harmful and clearly can be carbon neutral. Personalised attention and support from healthcare practitioners is often very well received by our patients. Talking about preventative therapies through changes to activity and exercise, nutrition and food consumption, social supports and general well-being can significantly improve the patient's health, not just for the particular concern of the moment, but more broadly. By focusing on enabling our health and hospital systems to be patient-centric and outcome-focused, using the models developed with value-based healthcare, we can reduce the carbon footprint of our healthcare system by reducing low and no-value health interventions. This would simultaneously offer us a healthier and happier population and make meaningful action on the health sector's contribution to climate change.
Thank you, Anna-Greta. Anna-Greta will be joining us for the panel discussion at the end, so please enter any questions you have for her in the Q&A function as we go. Next up, we have Vicki Bennett, who will be talking about collecting and collating information on the health impacts of climate change to enable governments and health systems to plan for and manage these new and emerging challenges. Vicki is the head of the Metadata and Classifications Unit at the Australian Institute of Health and Welfare, where has held a number of different roles over the past 14 years. She has a degree in health information management and a master in health informatics and has had a diverse career both domestically and internationally. She has worked extensively across the Pacific over the past 19 years, and she's recently been appointed as an advisor to the Pacific Health Information Network Board, and also as the president-elect for the International Federation of Health Information Management Associations. Thank you.
Hello, my name is Vicki Bennett. I am the head of the Metadata and Classifications Unit at the Australian Institute of Health and Welfare, and I'm speaking to you today from Canberra, Australia. I would like to be in Barcelona instead, but here I am in lockdown in Canberra due to the coronavirus. But I would like to start by acknowledging the traditional custodians of the land on which I meet, the Aboriginal Ngunnawal people. The Australian Institute of Health and Welfare is our national body for reporting on health data in Australia. I'm going to be speaking today about the importance of health data in understanding and reporting on climate change and environmental effects on human health. Being able to effectively report on the impacts of climate change on the health of populations is an emerging issue. You can't manage what you can't measure, is something I like to say. Collecting and collating information on the health impacts of climate change enables governments and health systems to plan for and manage these new and emerging challenges. However, methods for measuring and monitoring of environmental and health change impacts of delivering care are beginning to be developed, but they are still in their infancy. Collecting and collating information on health outcomes has a long history globally, especially for mortality. Those of you who've studied epidemiology might know more about this, but we have been collecting mortality data globally from as early as the 1850s. In 1948, the International Classification of Diseases and Health-Related Problems was first adopted by the World Health Organization, and there's been roughly a revision to that collection system about every 10 years. The system we're using at the moment is the 10th edition for mortality, which was first released for public use in 1992. As you can tell, a bit out of date. And then in 2019, the 11th edition was accepted by the World Health Assembly with a planned implementation for 2022, although we acknowledge the world would not move to that globally at the same time. So we are also collect in some countries good information on morbidity or disease information, but it is certainly not as well done as we have for mortality. Some countries do have excellent morbidity data collections like we do in Australia and many other developed OECD countries. And we have our own modification of the ICD-10 called the ICD-10 the Australian modification. And these national modifications allow us to capture extra clinical granularity and are able to readily be updated to include new codes to meet emerging needs. You can see below some examples of what we are able to capture in external causes that would help us to be able to report on climate change issues such as exposure to excessive natural heat or exposure to excessive natural cold. The coverage of ICD of health impacts of climate change currently in the ICD-10, it does have a number of codes that can allow for us to capture information for both morbidity and mortality in understanding the underlying impacts of climate change on health. For example, as on a death certificate that is coded with the ICD-10, you are now able to capture information on things like heat stroke or sunstroke as that underlying cause. So there is some data available in most countries on this. Some local research that is being undertaken in Australia is starting to try and look at health outcomes that we can measure using existing ICD code sets. And these can be related to things like respiratory health, heart health, brain, heat, cold, burns, deprivation, and then some of our external cause codes around environmental and social issues, which are also important to report upon. I mentioned earlier ICD-11, and it certainly is out there for future use, and many countries globally are planning for its implementation. It is a significant advancement on the current ICD-10. It has over 8,000 codes in its foundation. It is designed to be integrated electronically into information systems, which should allow it to be more electronically capture of data in most systems. It also has supports the customization of different what they call linearizations or use cases, perhaps for specific areas. And so perhaps climate change and environmental health could be one of those for the future. And it also supports and updates the terminology and use, for those of you who might know anything about it, that supports the dramatic medical and technological advancements that we have seen in healthcare since ICD-10 was first released in 1992. and it certainly includes more ability to capture impacts of health and climate change. And where I work at the Australian Institute of Health and Welfare, we are a WHO collaborating centre for the development of the international classifications. We are also developing globally a thing called the International Classification of Health Interventions, and it is also planned for rollout globally into the future. And you can see there in the list of its contents that it has a whole chapters 22 to 27 interventions designed around environmental interventions, and that public health interventions generally have a specific target in this area. It allows us to capture information, it will allow us to capture information on things like outdoor air quality that have impacted on an episode of care. And the use of a base code with additional strings added to it allow us to create a much more granular clinical picture of what has happened and what is happening to people. But moving away from what we can capture, I think it's more important that we focus of what we're doing with the data that we can capture and that we do capture in many countries. I've worked in many developing countries and much data is captured, but very little is used. And I think that's where it's important to understand how we use data to measure impact. Many global entities are trying to measure the impact of climate change. And this is just an image of a link to the OECD Key Environmental Indicators document. Each of the indicators outlined in this document start with a statement that notes that the reason that they're so important is because we need to understand their impact on human health. As I mentioned, I've worked globally a lot, and one of my roles at the moment is to be a WHO advisor to the Pacific Health Information Network. And under that banner, I am, and through my day job, also doing a review of the Pacific Islands Healthy Island Monitoring Framework. The reason that I'm highlighting this today is that we know that climate change is a challenge for all countries, but more so for some. The small island nations of the Pacific are in particular need as they are facing the brunt of changing weather patterns, including cyclones and rising sea levels that impact not only their landmass, but their fishing areas. So what is the Healthy Island Monitoring Framework? Well, in 1995, the Pacific Health Ministers declared that they had a vision for healthy islands, that where children were nurtured in body and mind, environments invited learning and leisure, people work and age with dignity, and more importantly to this presentation, ecological balance is a source of pride and that the oceans are sustained and protected. In 2015, they recognised that if they were going to try and progress towards this vision, that they needed a way to measure how they were going and monitor that. In response to that, they delivered an indicator framework, and the fourth pillar of that framework is completely related to ecological balance. And in the framework, there are 5 mandatory indicators, and these include populations using clean fuel for cooking, heating and lighting, resilience to climate change and national disasters, populations using improved drinking water sources, populations using improved sanitation facilities, and the number of vector-borne disease outbreaks, which includes things like malaria. And these all help understand how people are living within a safe way within their current ecology. There were also optional indicators, 9 of these, which I won't go into detail for, but they do include things like the share of coastal and marine areas that are protected, the area of public and green space as a proportion of the total city, forestation and cultivation, how solid waste is dealt with, And these are not insurmountable issues for small island nations that are less developed than many of ours. Returning to not only the need of countries to understand how they're managing climate change and its burden and impact on health, I refer to some of the other presentations in this session that talk about the need to collect information on environmental impacts of delivering health care. In Australia, we have a thing called the Australian Health Performance Framework, which is the diagram outlined at the bottom, which you won't be able to read, but feel free to have a look at it on our website. Health systems themselves are not currently collecting much data on the environmental impact of their service delivery. Our Australian Health Performance Framework currently has no indicators related to this. We know that we need to do more about this in the future, but we need to get good agreement from governments that they understand that the impact of delivering healthcare to the environment and thus to the health outcomes of their clients, patients, and the whole population is important. We must do more in the future. We must do it nationally and we must do it globally so that we can understand the impact that we are having to our populations, not only through the delivery of healthcare, but through the way we impact and interact with our environments. As I said at the beginning, I work at the Australian Institute of Health and Welfare in Australia. We do have an area that reports on environmental health. We have had many environmental impacts, and Australia is one of those countries with extreme weather conditions. We have bushfires, we have cyclones, we have hailstorms, we have earthquakes. We are well equipped to help globally. Please feel free to be in contact with me, and I can put you in contact with those of my colleagues who are working more specifically in this area. And thank you for your time today.
Thank you, Vicki. And Vicki will also be joining us for the panel discussion at the end of this session. And next up, we have Dr. Kate Charlesworth, who will discuss primarily the role of primary healthcare in reducing the carbon footprint of healthcare. Kate is a public health physician in Sydney, and after working as a hospital doctor in Australia, Kate completed much of her public health medicine training in the UK. She was a research fellow at the London School of Hygiene and Tropical Medicine, and then worked in the NHS's National Sustainability Unit, the leading healthcare decarbonisation program in the world. Kate also has a PhD in low carbon healthcare and now works as a medical specialist in climate risk across Sydney North Primary Health Network and Northern Sydney Local Health District, which is the first such role in Australia. So I'll hand over to Kate.
Hello, I'm Kate Charlesworth from Sydney North Health Network, and I'm going to talk today in this presentation about the really critical role of primary care in this transition to a net zero high value health system. Okay, so this is what I'd like to cover. Firstly, there are two key tasks ahead of the health system. We need to mitigate and to adapt. And primary care will be critical in both of those two tasks. Then I'll be talking about the carbon costs of low value care. And so the importance of a value-based care focus in this shift to a net zero health system, and outlining Sydney North Health Network's climate and health strategy and providing examples of the ways in which we're actioning this. So there have been a number of reports over the past few months setting out the urgency of climate action. This one in September from the IPCC, which was described as the UN Secretary General as a code red for humanity. We know we are seeing and will increasingly see the catastrophic impacts of climate change on human health. But there's another whole angle to this that, of course, most people don't really think about, and that is that the health system itself is a major part of the problem. Globally, if the health system, the health sector were a country, it would be the 5th largest polluter on the planet. And so the irony is the health system, which is supposed to look after people, is in fact a major source of pollution. Carbon pollution, of plastic pollution, of air pollution, and those things are making people sick. And this is completely inconsistent with our core business and with the values of most health professionals. And so then for the health system, we have two main tasks. We need to mitigate. We need to transition to a net zero health system. Every sector, transport, energy, education, housing, is going to have to get to net zero, and the health system has a particular responsibility to do so. And from a primary care perspective, we can both reduce, act directly by reducing our own emissions, and we can also act indirectly by reducing the reliance on carbon-intensive hospital care. Okay? So that's the first task. And the second task, and this is equally important, is that we'll need to adapt. And that's because even if we stop polluting tomorrow, there are climate changes locked into the system for decades to come. And so we will need to be prepared and resilient for extreme heat, drought, bushfires, flood risk, and so on. Okay? And so the carbon footprint of the Australian healthcare system is 35 million tonnes of CO2e, carbon dioxide equivalent. That is 7% of our national emissions. And this pie chart shows the breakdown of that footprint. So you can see there that if you add together public hospitals and private hospitals and capital expenditure, it's a lot of capital expenditure as hospitals, that overall about half of that whole carbon footprint is from hospitals. And the other interesting thing, of course, is that pharmaceuticals, that dark green section, pharmaceuticals are almost 20% of the whole health system's carbon footprint. Now, from a primary care perspective, we look at general practice, that red section, that's only 4%, and community and public health, only 6%. So together, that primary and community health part is very low in its own emissions. And we know that effective and well-resourced primary and community-based care has very beneficial health outcomes and can help to reduce reliance on hospital care, and so reduce that footprint part, which is hospital care. And the other important note, of course, from a primary care perspective, is that GPs have a huge amount of influence also over pharmaceuticals, okay, because they do a lot of prescribing. So if you look at that, then GPs and primary care is really critical in reducing that carbon footprint. Okay, so how do you get to a net zero health system? These are the 4 principles from a clinical perspective as to how you would get there. Okay? And the first one is prevention. And that's because one type of carbon neutral system is a system in which we didn't have any patients. Everyone was healthy and well and independent in their homes and their communities. Okay? So prevention is always going to be a key consideration. And I'm going to bring in there patient self-care as well, because informed and engaged patients and models such as peer-to-peer models, social prescribing, compassionate communities, using link workers, all of these sorts of models come in there with that prevention and self-care principle. Then the third one is lean service delivery, and that's about minimising wasteful activities. So we know that low value care, it's essentially overdiagnosis and overtreatment, has substantial harms and risks for patients, and also costs. And those costs are not just financial, but also carbon costs. So an important principle in sustainable healthcare is reducing low value care. And then the final principle is about low carbon alternatives. And that's saying, okay, where it is appropriate to provide care, how do we choose the lowest carbon option? Okay. So at Sydney North Health Network, we are the first of 31 primary health networks across Australia to develop a climate and health strategy. Okay. And I've been appointed as the climate risk lead, basically to implement that strategy. I'd just like to point out that we work in strong partnership with Northern Sydney Local Health District, which provides the hospitals, runs the hospitals and a lot of the other health services in our area. Okay? So my role is actually across Sydney North and Northern Sydney LHD. So that's to roll across primary and tertiary care, which I think is a really important partnership and a great model in this area. So at Sydney North, we've done a lot of stakeholder consultation, both with internal and external stakeholders. And a result of that, we've identified these priority actions that we will be focusing on in the next 6 to 12 months. And I'm going to look at a number of these actions now, providing examples of the sorts of things that we'd like to do. Okay, so on the first two principles of prevention and self-care. As you can see on this cartoon, and as many of you would know, many climate actions will have a whole range of health benefits. Okay? They will mean cleaner air, healthier diets, greener and cooler cities, more connected communities, and so on. And this was a strong, these climate health co-benefits was a strong theme that came out of our stakeholder consultation. Okay? And so one of our actions is to work closely with councils, so local government organisations. A number of them, there are 9 of them in our region. A number of them have very strong sustainability policies, net zero plans, and so on. And they want us to work with them to apply a health lens over many of their activities. Okay? So making the health case for tree planting, for green space, for sort of community involvement, for clean air zones around schools, that sort of thing. Okay? Also, what came out of our stakeholder consultations was a strong focus on young people. We know that there are rising rates of eco-anxiety in a lot of young people in our region. And so working with them on this climate health messaging and helping to provide practical solutions that they can be engaged in and be involved in, we know is so important for their mental health. And of course, provide input to environmental actions. And then another thing they wanted, that our stakeholders wanted, was climate health messaging and resources. So we're working on those. Another strong theme that came out was about social prescribing. Okay. This is an example actually from the UK. This was an intervention run by a group of GPs, which was basically around care planning, social prescribing, link workers, and compassionate communities. And as a result of this intervention, they reduced unplanned hospital admissions by 14%, despite an increase of 30% elsewhere in the county. And they saved costs about 20%. And so this is not only has health and social outcomes, but also financial and environmental benefits. So at Sydney North, we'll be looking at expanding some of our social prescribing programs and perhaps looking at some others. And in particular, I just wanted to look at specifically at exercise, because if exercise were a pill, it would be like a miracle cure. Physical activity greatly reduces rates of, as you can see there, everything from cognitive decline to diabetes, mental health disorders, and some cancers. So exercise is a highly effective, low cost, zero carbon intervention. And we would like to bring in exercise and green space and tree cover into things like nature prescribing and green prescribing. This is an example in Adelaide. We'd like to look at some similar things in Sydney, and I know that in other countries this is much better established, to take advantage of the environmental and the health benefits, both physical and mental, of nature prescribing and green prescribing, and practical solutions of things like providing walking maps for GPs for local areas, green prescription pads, and so on. Lean service delivery. So Wiser Healthcare is a large research collaboration in Australia that is tasked with reducing low-value care. Okay? So as I said, overdiagnosis and overtreatment has harms and risks and costs, and these are also carbon costs. And Wiser Healthcare has actually recently launched Wiser Carbon Neutral, which is adding in a climate lens to their work and looking at not just health and financial outcomes, but also carbon outcomes and carbon costs of low-value care. This is from their website. You can see there on that pie chart, they've taken that from the Australian health system's carbon footprint and looked at it in terms of the grey section is buildings and electricity and gas, but 60% of our carbon footprint in this country is from clinical care. Okay? And so they've taken that 60% and translated it to the right. And you can see that bar chart, and that's, clinical care is about 21 million tonnes of CO2e. We can see that the proportion of that, which we know from Wiser's work and from the literature, is actually harmful care. So 2 million tonnes of CO2e we waste every year on harmful care. Okay? A further 6 million tonnes is wasted on low value care. Okay? So clearly, from a health, from a financial and from an environmental perspective, we need to reduce or eliminate low value care. Okay? This is one example from a primary care perspective from that group of researchers. They looked at vitamin D tests. We found that last year we ordered 4.5 million vitamin D tests in Australia, That's nearly one test for every 5 adults. We know that from the literature and from their work that 75 to 90% of vitamin D tests are unnecessary. And so those tests last year translated to a waste of more than $100 million and about 50,000 kilograms of CO2e. Okay. So again, strong case for reducing low value care and the carbon and financial costs associated with it. And then the lowest carbon alternative. So you can't choose the lowest carbon alternative unless you know what the carbon costs are. Because in the future, carbon will be as important as money. And it's going to be like a whole new currency. And health professionals will need to understand the carbon costs of everything that they're ordering and doing. In the UK, indeed, they're starting to train up health professionals in this. And one of our actions at Sydney North is to support some of our clinicians, some of our primary care providers to attend such courses. It's an educational outcome. And then consistently we see in terms of GPs, what comes up top on their list in terms of climate actions is about prescribing. Okay? We saw the big carbon footprint of pharmaceuticals. So prudent prescribing, deprescribing, lifestyle and social prescribing were themes that came up a lot in our stakeholder consultation and which we'd like to work on, both with providing support to primary care providers. And they've also asked us to go to national medicines and pharmaceutical organisations to ask for carbon labelling of medicines and to ask for carbon costs to be included in prescribing advice and in their messaging. That's one action that we have underway. And then specifically in terms of prescribing, the big carbon hotspot in primary care is respiratory inhalers. And that's because the hydrofluorocarbons that are used as propellants in those meter dose inhalers, they are potent greenhouse gases. So this is a huge carbon footprint in primary care. As you can see there on the slide, the dry powder inhalers are much less environmentally damaging. And so we've committed to work to provide sort of education quite broadly and information quite broadly for our primary care providers and to work specifically with some on some sustainable QI or sustainable quality improvement projects. And respiratory care is one area that we've identified for a QI project. Adaptation, I just have one slide on adaptation, but as I said at the start, it's equally important, certainly for primary care. In Australia, we're going to have to adapt and be prepared for all sorts of climate health impacts, from drought, bushfires, flood risk, and so on. But for our urban populations, the #1 climate health impact is extreme heat. Primary care providers will have to work with our energy colleagues, our sort of transport colleagues, and our urban design colleagues to look at ways in which to cool our city and to protect people from extreme heat. And there's a number of solutions being discussed in that area: greening cities, tree canopy, heat reflective surfaces, urban design, and so on. But in this example, in this article, they're talking about having heat refuges. So these are community spaces, churches, public libraries, community centres, and so on, that could be air conditioned, to which people could go during heat waves to be safe from extreme heat. That's just one example. So in summary, the health system will need to both mitigate and adapt. They're equally important tasks, and primary care will be critical in both of those. Low value care has substantial carbon costs, and we'll need to reduce that in our net zero transition. And at Sydney North Health Network, we are the first primary health network in Australia to have a climate health strategy, and that we're now working to implement that. Thank you very much.
Thank you, Kate. And Kate will also be joining us for the panel session just shortly. But before we do have that discussion, and please do enter questions in the Q&A on the Congress app. You're going to hear from myself looking at how we might use the value-based healthcare implementation framework that was developed by Teesberg and her team to embed consideration of the environmental impact in how we structure, deliver, design care. I'm Kylie Woolfolk, the Director of Policy at the Australian Healthcare and Hospitals Association. I started my career as a pharmacist before moving into areas around health workforce development, service implementation and system reforms. I have postgraduate qualifications in artificial intelligence, health economics, training and management, and I have a particular interest in the digital transformation of services and their sustainable and equitable integration in care pathways. Thank you.
Hi, I'm Kylie Woolfolk. I'm the Policy Director at the Australian Healthcare and Hospitals Association. I would like to start by acknowledging the traditional custodians of the land on which I am delivering this presentation, the Ngunnawal people in Canberra in Australia, and I pay respect to their elders past, present and emerging. Climate change is the defining issue of our time. As my colleagues have already discussed, shifting weather patterns threaten food production, rising sea levels, increased risk of catastrophic flooding. The impacts are global in scope and unprecedented in scale. And we're increasingly seeing these impacts in Australia, as we are across the world, with extreme weather events such as heat waves, fires, floods and storms becoming more intense and frequent. Climate change poses serious risk to health and to health services. It's not only the risks posed by extreme weather events and injuries, deaths, displacement and trauma that have physical, emotional and financial effects. Health services are placed under increasing pressure. Pharmaceutical and medical supply chains are impacted, and health professionals and emergency professionals themselves are impacted personally, limiting their ability to respond. Climate change also affects the social and environmental determinants of health: clean air, safe drinking water, sufficient food and secure shelter. And it's affecting the health workforce. For example, in our rural areas in the Northern Territory, recent research has shown that 1/3 of medical professionals intend to leave the area in the next 10 years as a result of extreme weather. Climate change is a stress multiplier, placing increasing pressure on vulnerable systems and communities. These events intensify health inequality. With health systems keeping people healthy at the very core of their reason for being, how are our health systems taking responsibility for protecting health? As it's been raised already, first, do no harm is considered one of the defining ethical principles underpinning the provision of healthcare. And yet globally, the health sector contributes to 4.4% of net global carbon emissions, an amount equivalent to the 5th largest carbon emitter on the planet. In Australia, it's estimated that the healthcare system contributes to 7.2% of Australia's total carbon emissions. Along with Canada, Switzerland and the United States, we are the top healthcare carbon emitters per capita. Australian health groups and medical groups have formed a strong consensus around the need for urgent action. And while there have been some progress to implement climate and health strategies within our state governments and individual health organisations, progress on a national scale has been slow. Climate and health strategies also typically sit separate from those for health reform more broadly. Quoting Professor Peter Doherty, in a health crisis, we look to health and medical experts for guidance on how to respond. The climate crisis is a health crisis, and the path forward can seem complicated. So I would like to share with you some work I did with my colleagues, Emma Hoban and Dr. Rebecca Haddock, to explore environmental leadership through a value-based healthcare strategy. In this paper, we look at how value-based healthcare transformation can provide a guide for considering climate change and its impacts on health and healthcare. Value-based healthcare is a global movement being used to transform health services and systems. We see it playing out internationally in the US, the UK, around Europe, Asia and New Zealand, and here in Australia. It's based on work initially led by Professors Michael Porter and Elizabeth Teesberg. In their 2006 text, Redefining Healthcare, Porter and Teesberg proposed the definition of value as being health outcomes that matter to patients for the costs of delivering those outcomes. Sustainability is often identified as an underpinning feature, but health services may focus primarily on economic sustainability, or rather the proper use of financial resources. In a universal health system such as Australia, there also needs to be consideration of the concept of social value, and the value-based healthcare encourages active participation of people in the design and delivery of their care, an important principle in supporting access and contributing to sustainability from a social perspective. Further, a crucial principle in the delivery of healthcare must be that improvements in health outcomes not be achieved by treatments which themselves cause poorer health outcomes because of their impact on the planet. Health services and regions around Australia appear to be considering the environmental dimension of sustainability independently of value-based healthcare. And what we would like to propose is purposeful alignment of the two concepts in practice. Building climate change resilience into models and systems of healthcare will require attention to both patient level, service level, and system level elements. Heathberg and her team last year published a strategic framework for implementing value-based healthcare, and it can be used to consider specific actions the health system can take in pursuing environmental stewardship. I'm going to briefly look at each of these now, starting with understanding shared health needs of patients. Fundamental to value-based healthcare is that care is organised around segments of patients with a shared set of health needs. Patient segments can be used to deliver targeted programs of integrated care to patients with high levels of needs, or in whole populations by ensuring that the healthcare needs of that population group in their entirety are considered. Value-based healthcare frameworks would support the development of patient segments with climate-related health needs, such as those at risk of heat waves, or it could create segments around specific populations, bounded areas, or large populations, such as in response to exposure to bushfires or floods. We saw this intent to understand shared needs during our summer of bushfires in 2019 and 2020, where the Australian National University commenced longitudinal research to understand the health needs resulting from poor air quality related to bushfires on the health and well-being of pregnant women, new mothers, and their babies. Due to the timing, this was also expanded to consider the impacts of the COVID pandemic. Importantly, we're looking at shared health needs, and this doesn't necessarily have to be shared conditions. The second element of the framework is around designing solutions. Designing solutions to meet the needs of population segments requires teams that not only address the clinical needs of patients, but also consider their non-clinical needs, which when left unmet, undermine health outcomes that can be achieved by people. This is relevant to climate change, where there is evidence that designing solutions that disregard the carbon footprint of healthcare and the threats of climate change undermine any improved well-being from health co-benefits such as clearer air, increased physical activity, and improved diets. In value-based healthcare, there is recognition that healthcare is realised over time. We move away from episodic assessments of the outcomes and costs of healthcare and look at the full cycle of care. And this aligns with life cycle assessments, which provide a method for estimating the environmental footprint of a product or service from extraction of raw material through material processing, manufacturing, assembly, transportation, use, and end of life. We can bring these approaches together to design solutions that reduce the carbon footprint of care pathways, as well as improving health outcomes. And there is a range of strategies that should be considered in that design. For example, as we have heard about from Dr. Hunter in this session, eliminating low-value care is an important element of this. Supply chains and procurement, where the methodology and specifications consider the risk beyond the cost and quality of the goods, services, or solutions purchased, is important. Technological innovation can be complex in the context of sustainability. On the one hand, it's critical to driving value through facilitating new approaches for delivering care more efficiently and effectively. On the other hand, it can be hugely resource intensive. It can be costly financially, environmentally, and socially, and wasteful if new technology drives overdiagnosis and overtreatment without improving health outcomes. Considering a full care pathway in value-based healthcare also extends the design of solutions to preventative health and primary care. Hospitals are the most resource-intensive element of Australia's healthcare system. Value-based healthcare will assist in reducing avoidable hospitalisations, keeping people out of hospitals, and reducing healthcare's carbon footprint. And we heard about this from Dr. Charlesworth in this session already. But the final example that I provided is improving waste management, and it is another consideration as part of the care pathway. A significant proportion of unnecessary waste produced by healthcare services represents both lost value and opportunity and results in an economic, social, and environmental cost to society. Creative solutions to reduce and recycle waste within health services both promote value and improve health outcomes through preventing health byproducts and pollution. As clinicians and services lead the design of solutions that improve health outcomes, we want to see them also considering the environmental impacts of those solutions. Here in Australia, health services or even professions within health services can be working rather independently. with various funders and often limited data sharing ability. In value-based healthcare, multifaceted solutions need to be developed collaboratively through dedicated teams that draw from an array of disciplines. And we need to see those teams incorporating expertise around environmental sustainability. Dr. Charlesworth, who joined us in this session, is a leading example of this in Australia. Fundamental to value-based healthcare is the measurement of health outcomes and costs as a team. This anchors care pathways and decisions around patients. Embedding sustainability would, for example, see climate-related health outcomes be comprehensively measured, including human health vulnerability to climate change, with trends monitored over time and the effectiveness of interventions analysed. This would require the development of outcome indicators, which Vicki has spoken about already in the session. Australia is yet to establish and implement a comprehensive framework of indicators that reflect the climate-related health impacts unique to the Australian environment. Internationally, ITROM is recognised for defining global standard sets of outcome measures that matter most to patients and driving adoption and reporting of these measures to create better value. What you can see from these standard sets is that it's not just the clinical outcomes that are important for measuring. Here you can see a range of mental, social and quality of life outcomes also promoted, encompassing the social dimension of sustainability. Explicit consideration of climate-related impacts or the environmental dimensions of sustainability is not apparent. However, they're also not excluded. Last year's development of a COVID-19 standard set, as shown here, is the first that considers a disease attributed in part to altered climate conditions. And importantly, as with all standard sets, includes measurements of outcomes that reflect the social and economic dimensions of sustainability, such as productivity and feelings of loneliness and isolation. When it comes to measuring cost, how do we incorporate not just the financial costs, but also the carbon footprint of care? The carbon footprint can align to some extent with the financial costs. For example, if a hip replacement lasts 3 years instead of 15 years, not only are patient outcomes reduced, but the healthcare system must also expend additional resources to maintain the patient's health in the future. These additional financial costs from the readmission for another hip replacement and the associated rehabilitation are typically captured in the value equation. However, social costs can also be identified, such as reduced productivity, as well as environmental costs, for example, from the additional healthcare required that is high emission producing, energy intensive and waste creating. In contrast, anaesthetic gases provide a clear area of focus where the costs might not align. And so we need to be considering the environmental costs explicitly. So to facilitate value-based healthcare reform that incorporates sustainability, in our paper we make 7 recommendations for Australia's health system. We recommend that environmental sustainability be encompassed in the national vision and strategy for outcomes-focused value-based healthcare in Australia. The vision must recognise the significant contribution of healthcare to Australia's carbon footprint as a cost within the value equation, but also view the natural environment as more than just a resource that serves humans, and rather recognise the complex interactions and interdependencies between species, including humans, and the natural environment to maintain health and equity. It also requires a deliberate focus on those populations who are most vulnerable to the impacts of climate change. We also recommend that strong leadership is demonstrated across the health system through a commitment to achieve net zero emissions. We recommend cross-sector and interagency partnerships formed at regional, state and national levels to enhance capacity and coordination and leadership in achieving commitments to climate change mitigation and adaptation. We believe that the appointment of sustainability officers is important in supporting health services, collaborating with clinical leaders. Thirdly, we recommend that data-driven improvements in the health outcomes of individuals and populations are enabled through climate-related health outcome data being standardised and collection embedded in regional, state and territory and national environmental health surveillance systems. Also through life cycle assessments of the carbon footprint of health services, including both direct and indirect sources across the full supply chain being explicitly identified as a cost within the value equation when evaluating pathways of care. Health services must be supported to collect and report climate-related outcomes and costs of healthcare in order to track patient and population progress over time and to facilitate benchmarking between clinicians, services and regions. We recommend that health services are supported in the implementation of value-based healthcare through effective partnership governance models and the pooling of funding to identify the climate-related health needs of the populations they serve, with particular focus on those populations most vulnerable to climate change. We want to see a collaboration to design care pathways that optimise patient outcomes and minimise the impact of the climate, including through reducing low-value care, the effective and sustainable adoption of technology and virtual care models, preventative health action, shifts in products and services to lower carbon alternatives, shifts in care from high-emitting hospitals to primary care models where care is provided closer to home, and improvements in waste reduction and management. We recommend that health workforce strategies and plans consider the impacts of climate change. They need to recognise the impact that climate change will have on exacerbating health workforce shortages, particularly in rural and remote areas and already vulnerable communities, and the role value-based healthcare can have in facilitating the design of care models with safe, effective and innovative use of the workforce. Workforce plans must ensure education and training for all health professionals incorporates the impact of climate on health, and that they support profession-specific leadership in identifying actions to reduce carbon emissions and address climate-related health outcomes, with the sharing of best practice within and between professions. We recommend that funding models are introduced to incentivise environmental sustainability, including such things as low-interest loans, tax incentives and seed funding to support innovation at all levels of health system funding. We want to see funding models that explore blended provider payment models where explicit quality incentives incorporate environmental measures and explicit requirements for health technology assessment applications to include results from environmental impact assessments along with the impacts on health outcomes and costs. And finally, we recommend that there is ongoing support for climate and health research that provides that strong evidence base that we need to support health sector sustainability. The climate crisis is a health crisis. It can be complex, but there are clear strategies that must be pursued by leaders across our health system. And you can read more about it in our paper here. Thank you.
First question. In the UK, we hear about the worried well, patients who use primary care resources unnecessarily, which of course has a carbon cost. Is there a public education element to the work in Australia to tackle this? I might hand to you first, Kate, to respond to this.
Hi, Kylie. Yes, thank you. Look, I think there is. I think that there certainly is for a whole bunch of reasons, and carbon and environmental impact is one of them. But I mean, you have to think about what's the core reason of people seeking care. Is it because, you know, they're lonely or there are things going on or they don't have the right supports in their community, or if they're, you know, not managing well? So I think there's an important space here for things like social prescribing, compassionate communities, really strong community-based care, you know, and those sorts of models, peer-to-peer models and so on, which we're starting to see. But that, you know, those are, in a sense, sustainability measures, and that's all about, you know, keeping people healthy and well and independent, you know, and happy. So, yeah, I'm happy for others to jump in, of course.
Would anyone like to add to that?
I agree with Kate completely. It's often, it really is. It's not that we need to stop that from happening. We need to understand the reasons why people need that attention and care, and how we can do that better in our society. So it's a really lovely and really important question to ask. But I don't think it's about blocking access to support. It's thinking about how we can do that in a creative way.
Thanks. So our next question is about telehealth and other virtual models of care, which are often highlighted as ways we can reduce, for example, emissions associated with travel for healthcare. Is it really this simple, or how can value-based healthcare ensure telehealth is adopted with consideration of the impact on our planet? So who would like to jump in on this one?
I'll start if you like, but I know Anna Greta has some, you know, good personal experience as a cardiologist in this. Look, I think telehealth is, if we think about getting to a net zero health system, telehealth is going to be an important part of the solution, but we have to look very carefully at what's actually involved. And there is some research coming out saying that actually in some cases, because doctors can't see patients, they're actually more inclined to order extra tests or do extra investigations. So that, of course, has a carbon cost as well. So I think it has an important place, but we just need to think very carefully about where that is. Perhaps in the initial consultations or where there is, important things. And the other question, I was talking to a lot of respiratory physicians today about remote monitoring. What sort of information do they have? We really need to think about how we can get clinicians the right information so that telehealth is best used, I think. But Anna-Greta, you might have some comment.
Yeah, no, Kate, you made all the points I think that need to be made there. So I've done some telehealth over the course of the lockdown, and it works really well for patients that in short consultations, and you cannot assess a new patient, particularly as a cardiologist, without actually seeing them, and a physical examination is still an important part of what we do. And I've certainly seen in clinical practice that the telehealth system can lead to a significant over-investigation triage, and so you end up more likely to do a variety of flow-on tests. The other option we should be considering if we're thinking about how to minimise that carbon footprint of travel is systems to have doctors travel. So, I do a regional clinic and I go to a town that's 2 hours away from Canberra, and I see about 35 patients in that day. And so I save 35 or so, maybe more, trips back into the ACT. And so that's a significant carbon reduction by me travelling. And so that's the other thing that we should be planning within our health system, particularly in the Australian context where geography is an issue.
As long as you're driving in an EV, Anna-Greta.
It's probably sustainable for an EV, that's good. I was just going to add to that maybe that one of the challenges in Australia is that we actually don't have any data on telehealth particularly. We don't have ways of measuring telehealth services. We don't know if we count the service at the place it's delivered, i.e. where the practitioner is, or at the end where the patient is, and understanding sort of how we're counting and capturing information about the service delivery will be a really important metrics so we can understand, are we actually improving things? Because it's anecdotal to say that telehealth will improve things, and we're all guessing that it's probably better, but we really just don't have any data on it yet. So, we just need better metrics on some of these things. And certainly we're working at the national level where I'm working. We have a telehealth working group to start to talk about how we capture data on this, but it's still very, we're playing catch up to COVID, really.
Thank you. I'm going to move on to the topic of workforce. There was the research in Australia that showed that climate change will have a detrimental effect on our health workforce, continuing to work in rural and remote areas, which are areas where people are already, where there are already vulnerable communities. What can the health system do to ensure that the health and wellbeing of these communities are protected? I'm not sure if this links with the telehealth question as well, but possibly.
Yeah, so that study was done out of the Northern Territory, and I know some of the people who are involved in that research and that discussion. And it reminds me that, of course, climate change in Australia will have regional variability to it. And when we look at temperature rises, particularly that northern half of Australia, the predicted temperature rises over that period, that area, and particularly the number of days of heat stress is projected to be somewhat horrifying. And certainly if you're looking at the 2.7 degree and above modelling for the future, there are large parts of the Northern Territory where human habitability are questionable. Now, that's a really difficult question, I think, for countries, and there are countries around the world that are facing these questions about where we can live and how we can continue to live on an island as sea levels rise, in the centre of a very hot country as temperatures rise, on a coastal area as storms become more significant. And that's what that particular piece of research shows. We know that resourced people who have opportunities to move because of different employment opportunities, may be the first to leave when we're up against the climate stress that is there in the future. And that's really what that Northern Territory data shows, is that the doctors who are looking at the climate change around them are beginning to wonder about the sorts of temperature rises, particularly that they're going to face in the future. And they're wondering for themselves and for their family and for their communities, how on earth we can protect those communities issues if we don't address and rapidly decarbonise our global population. And so look, that's a really sobering set of information. And I'm not sure what the Australian response should be. I think it's time to have an honest conversation about the potential threat for habitability. We really need to have those conversations to understand the magnitude of what our future might hold.
Look, I would just add into that, probably from my experience in the Pacific, you know, and I mentioned this in my presentation, is that our Pacific Island colleagues are probably some of the countries in the world who are struggling the most, going rapidly underwater, higher than usual temperatures. Again, sustainability of workforce. You know, we are training health workers to work in those countries, but if you have an equivalent degree to something that would get you a job in Australia or New Zealand, why wouldn't you move your family somewhere where you feel it's safer? That they struggle with, obviously, all of the same things Anna Greta just outlined for Australia, but sometimes even more so because they don't have the social infrastructure to support. Like when a hospital is hit by a cyclone, it might take years to rebuild. So, you know, those climate impacts are very significant to them. I mentioned the Healthy Island Monitoring Framework. You know, the Pacific Island communities have a very strong focus on trying to preserve ecological balance, because not only is their land mass very important to them, but the seas that support them, the oceans, you know, the rising sea temperatures will have impacts on their fishing, their food sustainability. You know, there's so many reasons why. Not only is it an impact on lifestyle factors, but it is on the health outcomes of individuals and their communities that it's really going to be pushing. You know, we see it in Australia, but we have an economy that I guess allows us to make choices. Many of these lower and middle income countries, small island nations, really just don't have the choices to make. And so I feel it's our global responsibility to be addressing these issues, not just for our own country's sake, but for those around us who may have no choices themselves to make.
Thanks, Vicki. You raised the idea, you know, that we need to have this national conversation. Last month in Australia, the Climate and Health Alliance launched Healthy, Regenerative and Just, a vision which outlines the necessary policy reforms for a better future and calls on our governments to pursue these measures. We've heard some pretty disappointing conversations with COP26 over the last week or so. How important is a comprehensive, nationally coordinated response to the climate crisis and supporting healthy and resilient communities? And what responsibility does the health system have in ensuring that there is action taken? Would anyone like to have a go at that one?
Oh, look, I'll get started. I mean, certainly we need, certainly we need a national response, but we haven't seen it. You know, there has been a complete failure of an appropriate response at a national level look at the transition risks or the physical risks of climate and health. And I think what we're seeing is that states are stepping up, you know, not just outside health, but much more broadly. You know, in the news this week, our Treasurer and in New South Wales, our Treasurer and Environment Minister is forming a coalition of a number of the states with some international counterparts as well to push these sort of policies. In health, we know that some organisations are stepping up. The Australian Commission on Safety and Quality in Healthcare, for instance, is developing a climate risk module. A lot of states are developing state sustainability units. That's what we're doing in New South Wales Health. We started working on that last week. So that they will sort of fill the gaps. And then, of course, there's a lot happening at a local level. I mean, just in my experience, there is great pockets of practice going on all around the country, but nowhere near the leadership and the coordination that we need. And we're not, you know, so there's a certain amount that we can do, and, you know, the states and things will pull things together, but really that, you know, that national absence of national leadership really leaves a gap.
Thanks.
Yeah, and it's not just, I couldn't agree more again with Kate, sorry, but it's not just with the climate and health strategy or the absence of a climate and health strategy. It's a piecemeal approach from the whole government in terms of climate response. when we start to look at the magnitude of the threats and the changes that we're up against and it's the near future. It's now, it's Black Summer that we've been through 2 years ago. It's the flooding that we're experiencing across parts of Australia this weekend. We actually need to start to build in climate change and climate science and our health response into all areas of government. And so we need to shift how we work on these problems away from our siloed approach into a whole of government type response. When we start to look at the health impacts of climate change, they're very real. And if we're looking for a reason to act on climate change, it's for our human health and well-being. It's for our survival. It's for our opportunities to flourish into the future. And if we really do want to create a world where we are well and where we are healthy and where we are happy and where we are sustainable, we need to change how our policy approach to these issues is run.
And I guess I'd add to that is that we won't change our policy response until we've got good evidence. And we don't, look, Australia, and as a federal employee, I won't make it comment on the national federal response to any of these things, but as a federation, it is a challenge for us to get, consistent policies, consistent opinions across government. I think every country who has a federated system struggles with the same thing. And then if you take that out to the global perspective, it's getting, something like the COP29. Like, how do you get multiple countries to agree to the same things? It's a bit like getting, for us, multiple states to agree to the same thing. I guess we've got to go back to the first principles. We're human. Do we not all care about humans? Let's try and bring a human-centered approach to the way we do this. Obviously in my day job, I'm interested in counting things. We want to count things. We don't have anything in our Australian health performance framework around climate change. We don't have anything about environmental health. Like, unless we can start to measure some of those things, I think I said in my presentation, you can't manage what you don't measure. So unless we can start measuring some of these important impacts that the health system is having on climate change, and that what climate change is having on health impacts to our citizens, both nationally and internationally, I think we need to do that. And I guess because this is a global conference, it's not just what we need to measure in Australia. There is still not a very good representation in the WHO sort of indicator suite around some of those environmental health impacts. And I think, we could be working globally to do a lot more in that space.
I just wanted to follow on that. Sorry, Vicki, because data is, you're so right, the data is central to this. And we've been running a project with the Australian Cardiovascular Alliance looking at the environmental determinants of cardiovascular disease. And I think one of the agendas that's emerging from that discussion is to shift the paradigm of health away from a disease-centred diagnostic framework where we're centred around the biology of health to a much broader framework that includes the society that we live in and the environment and the environmental influence on health and well-being. And if we started to put that into everything, we put that into our hospital data, we put that into our clinical data, we put that into our clinical guidelines, we put it into medical school, we put it into our training in the postgraduate field, and we just simply attributed it. We recognise the influence that air pollution or air quality, the temperature variability, that the food that we eat, the water we drink, and the places that we're living and the sorts of environments in which we find ourselves might influence our health and well-being. The moment we start to build that into our paradigm of health and well-being, we will recognise, one, how important the environment is to us, and two, the magnitude of the threats we might be up against in the future.
Thanks, Anna-Greta. So I guess I will just ask each of you if you could just give, I guess, a final sort of summation of what one thing, let's talk a short-term action, a 12-month action that you'd like to see the health system take in, I guess, bringing environmental leadership to, I guess, globally. I'll start with you, Kate.
Oh, I knew you were going to say that. I think a good model is to do something individually, do something at your hospital, and do something more broadly. So everybody can make a change in their clinical practice or in their day-to-day work, whatever that is. It's a good motto just to do something. Whatever you can, you get up tomorrow, you do something. And then for I think you have to go to your hospital as well and ask whether they've got a net zero plan or a sustainability plan. Get some leaders together and go to your hospital exec or your health district exec and ask for that. And then more broadly, get involved in an organisation. So in Australia, Doctors for the Environment Australia or CAHA or other organisations, and try to have impact. Health professionals have a huge amount of influence. We should be using it. We haven't as much as we should to date.
Thanks, Kate. Vicki, what would be your parting messages?
Yeah, obviously it's about measuring things that we don't measure now. I think, we don't have enough metrics to understand the impact. So there's a lot of work happening under the National Health Reform Agreement in Australia on an enhanced health data and trying to improve some of the way we measure things in Australia. So I think there's an opportunity for us to think about how we add in some environmental measures that maybe aren't too hard. Facilities are capturing a lot of information about, every hospital has a lot of, accounting information and data, and I just think you're maybe making better use of the information that might be out there, but that's not really coordinated and collected. And I think we could do that relatively simply in an easy way, but we just have to have the willpower to do it.
Thanks, Vicki. Greta.
I'm just going to repeat part of what I said before, which is if we think about our health and wellbeing as biology, society and environment, and we use that model in all the work we do, it changes how we feel about engaging in climate change action for both mitigation and adaptation. It really highlights the importance of and the potential opportunities and advantages of action, as well as the potential threats and risks that we have ahead. So it is time for a paradigm shift. We need to see that broader context of our human existence.
Thanks, Greta. Look, I have to thank you all so much for giving up your time and being part of this panel session with us. It's an area that I know you are all very passionate about, as well as we, and we're really keen because I know IHF are also doing a lot of work in the sustainability space as well, and we look to engage with our global community around this too. That's the end of this session. Please, everybody who's in attendance, share your key takeaways from the session and post it in the Congress app and on social media. The recording of the session will be available on the event platform in a few hours. There will be a short break for those of you who are in Barcelona, but during this break, there are virtual presentations that will be shown in the event platform and in some of the rooms on site. Please check the app for the session information and location of the rooms. Later today at the closing plenary session, the Minister of Health of Catalonia and the Director General of the Dubai Health Authority will share key features of their hospital and healthcare delivery systems and discuss the importance of international collaboration. Don't miss that session. Thank you so much for joining us. Thank you, everyone.